introduce our first speaker for the day, Professor John Grigg. So John Grigg is a Professor of Clinical and Experimental Ophthalmology. He leads inherited retinal disease clinics at the Safe Sight Institute, Sydney Eye Hospital and the Children's Hospital at Westmead. He's an expert in his field, so we're really privileged to have him here today. He's leading several research studies, clinical trials for inherited retinal disease in Australia, and he's presenting today a short introduction for inherited retinal diseases. Thanks, John.
Thanks very much, Eden, and thank you to the organising committee for the opportunity to present here today. So I'm going to give an overview of an introduction which will set the scene for the rest of today's lecture. So really the first thing we have to do is define what is an inherited retinal disorder. And so these are a group of heterogeneous genetic disorders with diverse biological pathways that culminate in usually bilateral and symmetrical degeneration of retinal photoreceptors and all their connections accompanied by visual loss. So that gives us a way of setting it, because when you Google this, it's hard to find a definition. The next question is, why should we be involved? Many of you here have vision impairment due to these conditions, but why should the government concern? We had a nice speech and introduction from Minister Butler, who did highlight that over the last 10 years, the most common cause of registration for legal blindness is inherited retinal disorders. So this is the first time in 50 years that this has occurred. What that means is that the other conditions have now got effective treatments, and so people aren't losing their sight. So diabetes is the most common cause prior to this, but now there are effective treatments. So in effect, treatment for inherited retinal disease is where diabetes was about 30 years ago. So we have an opportunity now to try and catch up and try and bring hope and relief and some vision repair. I'd like to just sort of set the scene of what the spectrum of the disease is. So the IRDs are a heterogeneous group of conditions, and there's lots of different names, and those who can see that there's a pie chart there which sort of highlights that the most common grouping is rod cone dystrophy, also commonly called retinitis pigmentosa, which make up about 40% of these conditions. Stargardt disease is the second most common, the third is Usher syndrome, and then goes down to sort of the other sort of conditions like achromatopsia or choroideremia or latest congenital amaurosis, which sort of occur in 1 to 5% of people. There's still a whole group of other disorders, and that's partly because these conditions are genetically heterogeneous. We're going to hear a lot more about that today, but there's over 280 different genes that cause that. One of the challenges in managing these conditions is that one gene can cause multiple different phenotypes, or multiple genes can cause the same phenotype. And so that's quite confusing when you're trying to investigate this, and that's part of what we'll try and go through today. So here we are, sort of another way of looking at what are the most common genes involved in inherited retinal diseases. So the most common gene is the ABCA4 gene, and that's the one that's commonly associated with Stargardt disease, but can also cause a cone rod dystrophy and also retinitis pigmentosa. And in effect, 1 in 25 of us actually carry a defective copy of that gene, so it's very common in the community, as common as cystic fibrosis. The USH2A is the second most common gene, and the third one is RPGR. So that gives us a spectrum of what we're thinking of and how we approach sort of managing this. But there's 280, as we said before, and so we have to sort of try and work out how all these work, and then understanding how they work in the eye gives us insights into how we might look at therapies. Now this is a picture, on the top row is what you'd often find if you Google your conditions, so the Stargardt's, cone rod dystrophy or retinitis pigmentosa. They're the classic textbook images. But on the bottom row are pictures that are essentially normal looking retina, healthy retina. The trouble is that those normal ones actually have the same disease. So that's part of the challenge in managing people with these conditions, is you can have a textbook case where you might have one that looks like normal. So then we need to have an approach as to how we're going to manage and work out what condition is going on. And so we've worked as a group, many here have contributed to developing the Royal Australian and New Zealand College of Ophthalmology guidelines for managing inherited retinal diseases. This is something that was published in 2021, but we've been working on it since 2019. And it's a document that's freely available on the college website. But there's 4 broad areas there. The first thing is, in managing this, we have to establish the clinical diagnosis of inherited retinal disorder. We then have to determine the level of visual function and arrange visual rehabilitation. Then we have to establish the genetic diagnosis and the appropriate genetic management. And then there's monitoring disease progression, which is natural history, and preparing for therapeutic intervention. So they're the sort of four overarching categories in which we need to think about approaching the challenge of people coming with a suspected inherited retinal disorder. The next one is a more complicated diagram, and that's complicated because this is sort of the journey that you may go through trying to get management. And so that starts with people suspect that, you go to your primary healthcare provider, which might be a general practitioner or optometrist, then who suspect that. Then depending on your age, you might be referred to a paediatric ophthalmologist or a general ophthalmologist, and then they'll start the assessment process. The assessment process will be to try and see whether this is an isolated eye condition or whether it's associated with other systemic things such as hearing problems or kidney problems or neurological problems or other metabolic disorders. And once we work out that, then one branching pathway goes to visual rehabilitation to provide the support for education and employment. And the other part starts to try and then determine, more fine-tune the diagnosis, what type of inherited retinal disease that is. And that's being referred to an inherited retinal disease specialist. And basically, these people are based in the big academic teaching units in each of the states. So here in Sydney, it's at the Sydney Eye Hospital, the Children's Hospital Westmead. In Melbourne, it's at Royal Victorian Eye and Ear Hospital and the Royal Children's Hospital and CIRA. And in Brisbane, it's sort of at the Royal Children's Hospital there, or the Queensland Children's Hospital as it's called now. And so every state has this expertise, and part of it is that you need highly skilled people and equipment, need quite sophisticated equipment and the people to operate that. So these are things like the visual electrophysiology, the special imaging modalities that go, and people experience in interpreting this. And once we've got a ophthalmic diagnosis, then we can go down to the pathway of trying to find the genetic cause. And we're going to hear more about that from Alan, so I'll leave that. But just to highlight that the ophthalmology and the genetics go hand in hand, and you can't have one without the other. And you need to be able to interpret some of the genetics, you need to come back to the ophthalmology and so forth. And then finally, we need to, after we've gone through that process, we then have the management plans. And so that's looking at how might this person be involved in a therapeutic intervention. And so we have one registered gene therapy product in Australia, like Turner, or we might have availability for clinical trials, and we'll talk about that in a moment. So coming back to sort of the start of why might you suspect an inherited retinal disorder. So things about assessing is sort of what happens in the history, sort of what symptoms might you have, what change in vision, and how long have you had it. Sometimes medications can cause similar findings, and so that can confuse the issue. Is there a family history? Are there other medical problems that might be occurring that give us clues? When we come to sort of looking specifically what part of the eye might be involved, then do you have trouble with night vision? Might suggest that that's a problem with the rod photoreceptors, or if you have trouble seeing details or colour, you have trouble with cone system, or if you have trouble adjusting between light. And that's because when we're outside, we use the cone photoreceptors, and then we come inside, we have to swap the system over to the rod system. So if there's a delay, then that will give us a clue. So if you have difficulty going from outside to in or vice versa, that gives us clues. So then how do we investigate? The investigations are based in two broad areas, looking at functional measures of vision and also then structural measures of vision. And so the simple things that will happen at all the places, measuring your visual acuity for near and distance, seeing whether there's a need for glasses, sometimes that's all we needed. What's your colour vision like? And then we're looking at visual field testing, which is measuring the extent of your field of vision. Is it just a central eye on left or a wide field? And there's multiple different ways of measuring that now. Then there's sort of recording the electrical properties of the retinal cells, which is electrophysiology. And then there's sort of when people have got very low levels of vision, we've developed new ways of trying to measure what's the sensitivity of the retina with a full field stimulus test, and that's one of the outcome measures in clinical trials. Then structure, many people will have had these because it's quite widely available, so colour fundus images. We have technology that can take the whole retina in one go, often without having pupils dilated. Optical coherence tomography, which is like a cross-section of the retina, and then measuring some properties of the retina with autofluorescence. I've just put up this slide which highlights and trying to compare the eye to a camera. So you've got lenses at the front which focus light onto a film at the back, which is called the retina, and the retina is made up of the rods and cones, and they're the light receptors. So the rods are what we see used for our side vision and our night vision, and the cones for our detail vision and daytime vision. On the right hand here is this complicated wiring diagram, and that's one of the challenges in sort of developing therapies is to understand the wiring, how can we measure what part of the retina where the problem is, and then if we need, how can we intervene to try and correct it or replace it. But remembering that all these different cell groups, the photoreceptors, connect to an intermediate cell, which connects to the final ganglion cell, which connects to the brain. How do we sort of have the right wiring? Because without the wiring and without the connections, then we don't get the signals to the brain, which does the seeing. One of the ways we interpret that is with visual electrophysiology. And this is a complicated slide, but what the overall part of this is that with specific testing strategies, we can actually work out, is it a rod photoreceptor or a cone photoreceptor, or is it a bipolar cell? Which parts of the retina we can work out, and that gives us a great deal of detail and clues about what's going on. It can also tell us about residual function. When we do these tests, we can look at residual, particularly cone function, and give an indication of prognosis, how long we have useful vision. And by useful vision, we mean years of being able to do activities of daily living, like sort of dress yourself, sort of find your food, those sort of things. We can give some prediction with that with some of these tests. This second slide is we can delve further into how that central part of the vision works. We can look down at individual segments, just further refine how we understand and try and interpret what part of this is. And this is important to try and differentiate just one of the IRDs, which affects the macula mainly, which is the central vision, from the overall retina. This slide is very complicated, but it's freely available on the internet, and this is what we recommend for ophthalmologists when looking at people, how you should be followed up and what tests should be done. And we just divide up the inherited retinal diseases into sort of 6 different groups on those which have a so-called stationary disorder which affects the rod photoreceptors. Then there's the cone dysfunction syndromes which may include achromatopsia. Then we have the progressive rod cone ones, which is retinitis pigmentosa, progressive cone disorders, macular dystrophies, and chorioretinal disorders. So all those have an approach that has been agreed on in a consensus manner on what should happen, how we should help make the diagnosis, and then what we do to follow things up. And so, and some of that follow-up is how do we assess things to sort of see what sort of you can continue to do, particularly like driving vision and things like that. And at the bottom of that, you'll see one of the highlighted is that genetic testing is a critical component of all these assessments. One thing I did want to mention today is about driving and vision impairment. Some people feel that if you've given a diagnosis of an inherited disorder, then you shouldn't be driving. Well, we have a progressive, I think, group of people who developed the driving guidelines, and so the overarching goal is to keep the individual and the community safe. And so there are different classifications which then can enable you to sort of meet those standards. And one of those is a conditional license. And so if you've still got reasonable central vision, which is better than 6/24, which is halfway down the chart, and you've got visual field of 90 degrees, then you can have a conditional driver's license. It might mean you can only drive during daytime hours, or might be restricted with certain distance from where you are, but then that's all helpful in maintaining independence. And I think a lot of people aren't aware of these options, and often there's quite a few technicalities in the guidelines, and we do find there's sort of conflicting views in the eye healthcare teams as to who should be or shouldn't be having driving licenses. But we work with a group of people to help find a safe way to help people meet the goals if they can. Just to sort of in the conclusion, I'd just like to sort of give a quick summary of some of the inherited retinal disease clinical trials that are currently underway in Australia. So there's one for people with Usher syndrome using an antioxidant to try and preserve cone function called the Anacuity study. That has finished recruitment, and now we're waiting for the 2 years to sort of look at their results, and that's been recruiting in Sydney, Melbourne, Perth and Brisbane. There's one for Stargardt disease using Tinlarebant, and so there's an early phase 1/2 study which is concluded now, and there's a phase 3 study, which means it's a randomised study that's comparing the product to placebo, and that's ongoing. That finished recruiting, and that's for 12 to 20-year-olds in July last year, and so we have 2 years to wait for there. The preliminary results of the Tinlarebant study have been very encouraging. A slow progression of Stargardt disease by 50% compared to the natural history, and so that's really encouraging. Then the next one is the is following up the effects of gene therapy in the Veratogene Bavavac, which is for Lux-Turner, which is for the RP65 disease. Then this is what's coming in planning. So there's Janssen have a global registry for people with X-linked retinitis pigmentosa due to the gene RPGR and achromatopsia. That's going through ethics at present, and so Sydney, Melbourne and Perth are involved in that. Westmead is a new company that's come in looking at treatment for rhodopsin, people with retinitis pigmentosa due to rhodopsin mutations. That's going through ethics at present. Beacon Therapeutics is another US company that's coming to do a clinical trial for an RPGR gene replacement therapy, so we'll have that, plus the next one is Kiora Pharmaceuticals, which is an Australian-based company which is using a different method to try and reprogram those ganglion cells to be light sensing. And they've got a photoswitch molecule, and they're recruiting people with extremely poor vision, so less than count fingers vision, or even no perception of light. There's been a pilot study done in Adelaide with 6 people so far, and 1 person with no perception of light has actually gained some light sensitivity back. So these trials are sort of giving a broad spectrum. Some people are early in the disease process, some people right at the end. Then there's Avantgarde, who I'm a consultant for, who are looking at how to manage gene replacement therapy when you have very large genes like USH2A, which is Usher syndrome, or ABCA4, and they've developed some technology which has now been approved for use in Italy, and where they cut the gene in half and then reassemble it in the cells, is the simplest way of saying that. We have another company, PYC Therapeutics, which is a Perth-based company, which is looking at treatment for a specific type of retinitis pigmentosa due to a gene called PRPF31, and that'll be starting trials in Australia hopefully in the next 12 months. That's already started in the United States. And the last one is to mention that MiraGTX, which is licensed their product for X-linked retinitis pigmentosa to Janssen, they're very close to having results from a phase 3 study, and the phase 2 studies were very promising, so we hope that the phase 3 studies, and so that will then bring a therapeutic product for X-linked retinitis pigmentosa to Australia, and the group that speaking today are very involved in the regulatory approach for that. So just sort of to conclude, these days are great because it helps stimulate the researchers to understand the perspectives of the individuals, and certainly at the Sason Institute, this has led to us developing a patient care coordinator who helps people navigate the system, particularly the challenges of NDIS, or when you're first diagnosed with a condition, you leave the doctor's office with a phone number maybe, and it's very daunting what's going to happen. Also, we're looking at transitioning to different stages through to starting school, starting high school, or leaving school. We have a peer mentorship group that's being run by 2 of our good colleagues, Simran and Saloni Goyle. They also have vision impairment themselves, and they've taken on themselves to help navigate that university and post-university into the workforce. And they're having a preliminary discussion how to network and how to improve that and interact with business to do that. So just to conclude, this is a large collaborative group that requires many people to bring together the work to do this, from the clinicians, the special scientists from vision scientists to do the testing, and then through to the laboratory scientists and the people who run the clinical trials. So thank you for listening, and we have questions at the end of the session.